Okay, so let's go through pneumonia. So in this video, we're going to introduce what pneumonia is, and we'll also look at the initial investigation and also treatment and general management of pneumonia. So pneumonia is simply defined as an inflammation of the substance of the lungs. So it is mostly caused by bacteria, but it can also be caused by viruses and fungi. So most bacteria which cause pneumonia are Streptococcus pneumoniae. So these are gram-positive cocci, and in most cases 50% it is caused by Streptococcus pneumoniae. But we have others such as Haemophilus influenza, we have Klebsiella pneumoniae, and we also have Pseudomonas aeruginosa and Legionella haemophila, and we also have Streptococcus aureus and Moraxella catarrhalis. But 50%, remember, it is caused by Streptococcus pneumoniae. So the clinical presentation of pneumonia. So pneumonia will present with cough, which can be productive or dry, and the cough might be purulent with sputum. So purulent sputum, which is rusty in color, if it is caused by Streptococcus pneumoniae. Then we also have breathlessness, fever, crepitation, and chills. So those are the clinical presentations of pneumonia. So let's move on to the classification. So pneumonia can be classified using morphologically, can be classified morphologically, or the etiology. We look at what is causing the pneumonia, whether infectious or non-infectious. And we can also classify using the setting where it is contracted. So classifying pneumonia using the setting where it is contracted, we are going to classify pneumonia as community-acquired pneumonia. So that is if a person with no underlying immunosuppression or malignance acquires that pneumonia in the community, then that pneumonia will be called community-acquired pneumonia. Okay, so apart from that, we have another class which is hospital-acquired pneumonia. So this one is also called healthcare-associated pneumonia. Okay, so mostly this one is acquired in the hospital, or it can be in the nursing homes or other institutions where healthcare, where we have healthcare or institution where patients are taken care of. So that will be called hospital-acquired pneumonia. Apart from that, we have aspiration pneumonia, but in most cases, this one is classified under etiological classification. Okay, and we also have ventilator-acquired pneumonia, where we have a patient who has been put on a ventilator, and during that time or the period where that the patient is on the ventilator acquires the pneumonia. So this specifically is acquired due to the bacteria being in those tubes, and they form fumes, and in the process of breathing, the patient acquires the pneumonia. So this classification is based on the setting where the pneumonia was contracted. But moving further, we can also classify pneumonia according to the etiology. So etiological classification, that is, we can classify it using the cause, looking at the cause of pneumonia. So we have infectious and non-infectious pneumonia. So under infectious pneumonia, we said it can be caused by bacteria, it can be caused by a virus or a fungi. So bacteria, we already mentioned this. We have several bacteria which can cause pneumonia, such as Streptococcus pneumoniae. That is 50% of this infection is caused by Streptococcus pneumoniae. And then we have Haemophilus influenza, which might cause 7%, and we also have these others as we mentioned earlier. But for viruses, we have influenza virus type A and type B, and we also have parainfluenza virus, adenovirus, and coronavirus can also cause pneumonia. Okay, so for fungi, we have Pneumocystis jirovecii pneumonia, and we also have aspergillosis. So those are some of the fungal or parasitic pneumonia. So now, apart from etiological classification, we can classify pneumonia using the morphological classification. So for morphological classification, pneumonia can be classified as lobar pneumonia, which involve the entire lobe of the lung, or we have segmental or lobular pneumonia, which involves just part of the lobe. Then we have bronchopneumonia, which just involves the alveoli and its adjacent bronchioles. And then we have interstitial pneumonia involving the interstitial tissue. Okay, so for the lung is divided into lobes. So we have the left lung and the right lung. So the left lung has two lobes. We have the upper lobe and the lower lobe. And then for the right lung, we have three lobes. We have the upper lobe, middle lobe, and the lower lobe. So for the right lung is divided into three lobes by two fissures. We have the horizontal fissure and the oblique fissure. But for the left lung is divided into two lobes by an oblique fissure. So for lobar pneumonia, it will only affect one entire lobe. So if it is for the left lung, and let's say it affects the upper lobe, meaning we are going to have the upper lobe affected. So if it is the lower lobe, then we are going to have the entire lower lobe affected, as depicted in this X-ray. This is the chest X-ray, and then we can see we have consolidations of the middle lobe of the right lung. So this is the right, and this is the left lung. So we have this consolidation here, which shows the lobar pneumonia, that is of the middle lobe of the right lung. Then apart from lobar pneumonia, we mentioned that we also have what we call bronchopneumonia and interstitial pneumonia. So we have interstitial, where we have the interstitial tissue being affected, being inflamed. And then we have bronchopneumonia, where we have the alveoli and its adjacent bronchioles being affected. So on the chest X-ray, for interstitial pneumonia, we are going to have, it's going to look like this chest X-ray here. So here we are going to have reticular consolidations, where we have an appearance which looks like having a form of a net. So we are going to have something which looks like a ground glass appearance. Okay, then for bronchopneumonia, we have patchy consolidations or opacities. So like in this diagram, we can see we have patchy, which are uneven consolidations in the lungs. Okay, but in interstitial, we are going to have reticular opacities. Okay, so now let's move on to community acquired pneumonia. So under the setting where the pneumonia was contracted classification, we said we had community acquired pneumonia. So community acquired, as it explains itself, it is acquired in the community. So it occurs across all ages, okay, and it is more common at extremes of ages, such as those who are below 16 years and those who are above 65 years. Okay, that is what it means when we say common at extremes of age. So the most common cause here we have Streptococcus pneumoniae is the most cause, and it causes 50% of cases. And the clinical features for community-acquired pneumonia, so these features vary according to the immune state of the patient and the affecting agent. So if it is caused by Streptococcus pneumoniae, we are going to have different features. If it is caused by, let's say, virus or other bacteria, then the clinical features will be different. But in most cases, we are going to have a dry or productive cough. Then we are going to have breathlessness. We're going to have fever, chest pain. So this chest pain is caused by the inflammation of the pleura. So inflamed pleura will cause the chest pain. So the chest pain is pleuritic in nature. So that is, you can differentiate it from the one which is in angina or in myocardial infarction. So this chest pain here is pleuritic in nature, and it is caused by inflammation of the pleura. So another clinical feature, we have chills, and we can also have other extrapulmonary features, more especially in elders. In old patients, we are going to have confusion and recurrent falls. So these will also show that a patient have pneumonia. Okay, so what are the risk factors of pneumonia? So pneumonia, the risk factors, we have age. So those who are below 16 or above 16 years of age are at risk. And then we also have those who have comorbidities such as HIV infection, diabetes mellitus, chronic kidney disease, malnutrition, or recent viral respiratory infection. So those are at risk of pneumonia. Then we also have other respiratory conditions such as cystic fibrosis, bronchiectasis, chronic obstructive pulmonary diseases such as the COPD. Okay, and then we also have obstructing lesions such as the endoluminal cancer, inhaled foreign bodies. So those who have these conditions, they will have a risk for having pneumonia. Then also have lifestyle such as cigarette smoking, excessive alcohol, and intravenous drug use will also put one at risk of pneumonia. Then we have heterogenic. So under this one we have immune suppressant therapy. So those who have an immune system which is depressed will be at risk of conducting pneumonia. So for community-acquired pneumonia, the initial assessments will depend, or the investigations will depend on the severity of the illness. Okay, but for mild infections, we just treat the patient at home. So the patient will be treated as an outpatient with standard oral antibiotics such as amoxicillin and clarithromycin for patients who are allergic to penicillin. Okay, so for mild infections, you just treat the patient as an outpatient. Okay, so you treat the patient at home using amoxicillin or clarithromycin. But for us to know that this infection is mild or severe, we use a certain score which is called CAB 65. Okay, CAB 65. So CAB 65 or CRB 65 score, this stands for C, that is for confusion. Okay, so if the patient presents with confusion, then the score will be 1. Okay, so for all of these presentations here, the score is 1. So this is a score which helps to assess whether to admit the patient or to treat a patient at home. Okay, so for CAB 65 score, C is for confusion. So if the patient presents with confusion, then we are going to have the score of 1. Then we also look at the urea level. Okay, so urea level greater than 7 millimoles per liter, then the score will be 1. Then respiratory rate, if it is greater than 30 breath per minute, then the score also will be 1. Then for B, that is systolic blood pressure. If it is less than 90 millimeter mercury, then the score will be 1 as well. So if it is less than 60, that is systolic, and diastolic, which is less than systolic less than 90 and diastolic less than 60. Okay, that is the score will be 1 as well. Then for the age, that is 65 in the CAB 65 is for age. So if the age is greater than, the patient is have the age which is greater than 65, then we're going to have a score of 1 as well. So you consider all these presentations and come up with the total score for the patient. Okay, and remember that 1 point for each of the above. So meaning each of these presentations here scores 1 point. So if you have a patient who presents with the urea level which is greater than 7, respiratory rate greater than 30, and blood pressure which is 90, less than 90 over 60, less than 60, then we are going to have a score of 3. That is 1, 1, 1 here. So we add the score and come up with the total score. Okay, so now if the score is between 0 and 1, then you treat as outpatient. So you treat the patient at home. And then if the score is 2, you admit to the hospital, but in the general admission setting. And then if the score is 3 or more than 3, then you often require you treat the patient. This is an emergency, so you will be treated in the intensive care unit. Okay, and the mortality, remember here, it increases. Okay, so the mortality is more in if the score is great. So the mortality rates increase with the increasing score. Okay, so that's how to use the CAB 65. And the CAB 65 can also help us in the treatment process. So if the CAB 65 score is 0, then we should know that it is 0, then the mortality rate or the mortality risk is low, and you treat the patient at home. So home care appropriate. And then we do not need to do microbiological diagnostic tests in if the score is 0. The chest X-ray as well is not needed. And then from there we can just give oral amoxicillin 500 milligrams 3 times daily, or we give oral clarithromycin 500 milligrams twice daily, or we can give doxycycline 100 milligrams daily. Okay, so you remember that the initial loading dose is 200 milligrams, and then we can give doxycycline if the patient is allergic to penicillin. So you can give clarithromycin or doxycycline. Okay, so if the score is between 1 or 2, here remember the risk has increased, so we need to refer for assessment. So we can do other assessments, such as we need to admit the patient just for a short period of time. Okay, so if the CAB 65 is 1, remember the mortality here is less, the mortality risk is less than 3%, and it might be suitable for short stay for ambulatory care. So no microbiological diagnostic tests are necessary here, and unless if there is an outbreak suspected, or if at all it is mycoplasma epidemic. So if we have epidemic of mycoplasma, then we can now do the microbiological diagnostic tests. Okay, so but if at all these there is no epidemic, and an outbreak is not suspected, then there are no need for microbiological diagnostic tests. So you can just treat with the oral amoxicillin with 500 milligrams three times daily, or we give oral clarithromycin 500 milligrams twice daily, or we give doxycycline 100 milligrams daily. And then the loading dose, remember, it is 200 milligram initial loading dose. Okay, so if the CAB 65 is 2, the risk is 9%, so 9% mortality risk. And then here we need to do a blood culture. So we're going to do a blood culture or sputum if no antibiotics. Then we also do serology and PCR if we have an epidemic. Okay, so remember here also use the same medications as earlier, such as amoxicillin, clarithromycin, and doxycycline. So we use doxycycline if the patient is allergic to penicillin. Okay, so we are going to use doxycycline. Okay, so we are going to also if at all the CAB 65 is 4 to 5, then we need to give antibiotics as soon as possible. Okay, and we'll give amoxiclav, which is 1.2 grams 3 times daily, plus and this is given IV intravenously, and then we also add clarithromycin, which is 500 milligrams twice daily, and IV fluoroquinolone. Okay, so if Legionnaire disease is suspected, then we give fluoroquinolone. Okay, so now what other investigations can we do apart from just using the CAB 65? So we can look at a chest x-ray. So chest x-ray will show consolidations, as we observed on this slide. So the chest x-ray can help us examine if we have consolidations and the opacities. Okay, and also it can help us differentiate between how severe the infection might be. So in bronchopneumonia, we are going to have patchy opacities, like in this chest x-ray. And then in interstitial pneumonia, we are going to have reticular consolidations, which looks like a net form of having a form of a net, something like that. Okay, or ground glass appearance, like as we can see here. Okay, so for lobar pneumonia, also on the chest x-ray, we will observe one lobe being affected, so we have consolidations of the whole lobe in lobar pneumonia. Okay, so that is further investigations we can do a chest x-ray. Apart from that, we have a blood test. Okay, so the blood test, we can do the serum creatinine and electrolyte biochemistry, and C reactive proteins. Okay, and then for blood test, remember Streptococcus pneumoniae, we are going to have leukocytosis, so the neutrophils will increase, okay, due to the inflammation which is taking place there. Okay, and then apart from that, we have ESR as well, will be greater than 100 millimeter, and then we have C reactive proteins, which will be greater than 100. So if you observe this, then just know that that is Streptococcus pneumoniae, and remember the neutrophil levels count will increase. Then for mycoplasma, the white cell count will be normal. It's usually normal. Okay, so if the white cell count is normal, then you just know that that is mycoplasma. Okay, but we have the chest X-ray which suggests pneumonia, and then the blood test or blood culture shows that, or the blood count shows that the white cell count is normal. Then the agent or the etiological agent will be mycoplasma. So for Legionella, there will be lymphopenia without marked leukocytosis, so meaning the neutrophil numbers won't increase. Then we are going to have hyponatremia. So here we are going to have sodium concentration levels reduced, and then we also have hypoalbuminemia. So protein albumin in the blood will also reduce. Then we'll have high serum levels of liver aminotransferase. So this is a liver enzyme, so we are going to have elevation of this liver enzyme. Then other tests, we can have sputum culture or blood culture. And then we can also do arterial blood gas analysis, okay, also, and then we can also look at HIV test so that we know if at all they are immune suppressed. Okay, so for management, general management, we can now we need to maintain oxygen saturation. So remember here, if the patient is not a COPD patient, then we maintain the saturation at 94% and 98%. But if the patient is a COPD, that is chronic obstructive pulmonary disease patient, then the oxygen saturation should be 88% and 92%. Why? Because we are trying to avoid carbon dioxide retention due to loss of hypoxic drive. So in COPD patients, there is carbon dioxide retention if we keep the saturation at 94% and 98%. Okay, so another thing that we should do, we should also administer fluids intravenously, that is in hypertensive patients. Okay, in hypertensive patients, we need to administer intravenous fluids. Okay, so also need to give antibiotics, as I've explained in the CAB 65. So the antibiotics are administered as such. We assess using the CAB 65 and look at how we can do the treatment. Then if admitted for greater than 22 hours, we can also do the thromboprophylaxis to avoid the formation of the thrombus. So we give subcutaneous low molecular weight heparin, and then we also do the thromboembolus Durant stockings. So you give these stockings to squeeze the legs so that we do not have stasis of blood in the legs, in the lower limbs especially. So these can also be fitted, okay, So another management we can do, we can give nutritional supplementation and analgesia if there is chest pain. So we give paracetamol or an NSAID to help treat the pleuritic pain which is there. So now, what are the complications of pneumonia? So pneumonia complications are divided into two. We have the general complication and local complications. So general complication, we have respiratory failure. So you can have respiratory failure, sepsis, which is multi-system failure, and under local we have pleural effusion and empyema, we have lung abscesses and organizing pneumonia. So these are the complications of pneumonia. So thank you so much. Don't forget to like, subscribe, and leave your comment in the comment section below.